Okay, greetings. We are on our third and final adventure of diabetes. Now we're going to be talking mostly about the complications of type 1 and type 2 and some preventive measures to prevent those complications. All right. A lot of people with diabetes go along thinking, I'm okay. And part of that is because you can't see what diabetes is doing to the inside of your body until it's too late. Your lab values, as they're getting lab values along the way, will help with that some. But the truth of the matter is, a lot of times by the time the complications occur, we're talking about amputations, losing limbs. It gets very complicated. Massive heart attacks, strokes, because we can't see the toll that it's taken on the inside. So it's very important, again, to control those A, B, C's. The hemoglobin A1Cs, the blood sugars, the blood pressures, and the cholesterol levels. So with type 1, our big thing, one sometimes we have to worry about, is what's called DKA, or diabetic ketoacidosis. Now, there's two reasons we mainly go into DKA as a type 1. Either decrease exogenous insulin, in other words, poor compliance, not taking your insulin, or two, increase endogenous glucose, like steroids, that increase the sugar level so high. So let's look at the path though. We have hyperglycemia that results. Well, what does that do? That increases the overall serum osmolality. So the blood now becomes hyperosmolar. Well, we know that extracellular fluid draws from the intracellular fluid, draws intracellular fluid out because they're going from a lesser concentration to a greater, leading now to cellular dehydration and osmotic diuresis. As that DKA progresses, then glucose is in the bloodstream, but it's not in the cells. So the body thinks that it needs more in the cells. So now your G's are kicking in trying to help. It's trying to help out with storing it in the cells when it's actually making it worse. So this results in a further increase in glucose levels. Your free fatty acids are converted to ketones, and then you start building up ketones, which are acids. So now we start building up extra acids. Bicarb and sodium get lost through all the diuresis, and that's your buffers, so now they're gone. Your respiratory rate's going to start increasing. That's to compensate for that acidosis because you're trying to blow it off. Now we're back to our ABGs, trying to decrease that pH and blow off some of that acid. And the type of respirations that you get are what's called Kussmaul's respirations. Those are normal for someone who's in diabetic ketoacidosis. Acetone, fruity breath, because of the increase in the sugar. The serum potassium is very, very important. It may appear normal or elevated, but the cell is actually depleted. Remember, we are dehydrating those cells to death. We have pulled them out and shrunk them to nothing. So remember, one of the functions of insulin that we learned in part 1, that it transported potassium into the cells. Okay? Clinical manifestations of DKA: mental changes, confusion, nausea, vomiting, abdominal pain, hyperglycemia greater than 250, Kussmaul's respirations, fruity odor to the breath, hypothermia, hypovolemic shock, polyurea, glycoluria, increase in glucose in the urine, and a water loss anywhere between 4 to 12 liters. Holy cow. So what happens is your serum is hypertonic because you pulled out from the cells into the extracellular fluid compartment. But your urine becomes hypotonic because you're urinating so much. The hyperglycemia, usually greater than 350, and you will also have on your lab findings hyperkalemia. Now that, if you remember, you pulled it out of the cell, so it's what we call a transit hyperglycemia. It's not actual, it's transit. Because as soon as you put insulin on board to help with DKA, what did I say insulin did? It transports potassium back into the cell. So for the first 4 hours, you may see hyperkalemia. But from 4 to 24 hours later, you're really going to probably drop to hypokalemia. Because as soon as you give the insulin, it pulls it back into the cell. Therefore, you have to almost have something on board to help with that. So it's going to be really strange when you see a doctor order, give, this fluid for this long and then give, add potassium, because you're thinking, man, they already have a high potassium. But you've got to remember that's a transit hyperkalemia. It's not an actual. And as soon as you start an insulin drip to help with the hyperglycemia, that insulin, one of its functions is to pull potassium into the cell too. So when it starts pulling it out of that extracellular food back into the cell, it's going to leave the serum hypokalemic. Metabolic acidosis, because of the buildup of ketones. Remember, we were breaking down fats, breaking down proteins. May or may not have leukocytosis, depending upon the white blood count. Dehydration and increased serum osmolality, increased hematocrit, increased bun. Remember, anytime you've got dehydration, you're measuring the number of particles per the number of solution. So if I don't have very much solution, I've got more particles. So I'm going to have an increase in osmolarity and an increase in hematocrit, an increase in bun with dehydration being present. Management, IV insulin. We are going to give it at a slow rate, about 5 units per hour to 10 units per hour, and check sugars hourly. Hyperkalemia is very quickly reduced with fluid and insulin replacement. The initial fluid is normal saline, and we're going to give 1 liter over 1 hour or less. You're going to follow that with half normal, about 1 liter every 2 hours. Remember, they have lost a lot of fluid. Then you're going to add 20 to 40 milliequivalents of potassium depending upon the potassium level. They're going to be watching that very closely because of what we just talked about earlier, the transient hyperkalemia. Now, when blood sugar is about 250, a lot of times they'll switch over and may add like some D5NS, D5 half, because again, we've got to restore that glycogen in the stored forms in the muscle and liver because it's all been depleted as well. Acidosis is reversed with insulin because it inhibits fat breakdown. Once we have the insulin on board, we don't need to break down the fats anymore. Eyes and O's, vital signs. They may have to have some central venous pressure monitoring depending upon their levels. The hypokalemia is a major cause of death in DKA. So you have to watch that potassium because the deficit is intracellular, so don't be fooled by the level when you get it. That's why we have to administer potassium early. So just a little visual here. DKA starts in about 4 to 10 hours. It has a slow onset because of either a lack of insulin, could be because of illness, fruity smelling breath, Kushmal respirations, tachycardic, acidotic, high blood sugar, hyperkalemia, and increase in urination. What you need is a high E. You need hydration, insulin, and electrolyte replacement, potassium. Hydration, insulin, and electrolyte replacement. Now with type 2, we get what's called HHNS. I've always known it by HHNK, also known as HHS. And this is when the client produces enough insulin to prevent DKA, but not HHNS or HHS. This stands for hyperglycemic, hyperosmotic, non-ketoic syndrome. So we don't go into ketoacidosis with this type, but we still have the hyperosmolar and the hyperglycemia. We just don't have the acidosis. So it's a smaller version of DKA. So people with type 1 get DKA, people with type 2 get HHNS. So you still have the hyperglycemia, the osmotic diuresis, and the dehydration, but you don't break down fatty acids, so no ketones, so therefore no acidosis. Clinical manifestations will be higher blood sugar levels, usually 600 or greater, hyperosmolarity, and osmotic diuresis. Management is very similar, normal saline for the first 2 liters for the first hour of treatment, then switch over to half. When the blood sugar falls to 250, get some more glucose on board to restore that's been lost in the cells. IV insulin for hyperglycemia. It's not for acidosis this time, it's strictly for the hyperglycemia, where with DKA it was not. It was for 2 purposes. It was to stop the acidosis and for the hyperglycemia. So now we're going to give it at a slower rate. We're only giving it 2 to 5 units per hour for the HHNS. Now the potassium is lost too in HHNK, but not as much a concern because there is some insulin in the cells. Complications of type 1 and type 2. Hypoglycemia is defined as a blood sugar less than 60. And I think your book says 60, or maybe, I'm pretty sure it said 60. Etiology is too much insulin, too little food, or excessive exercise. Too much insulin, too little food, or excessive exercise. Now, even though that's their definition of low blood sugar, some people with a 70 start shaking. Some people don't start shaking until they get a blood sugar of 30. So when a person actually truly has a hypoglycemic reaction depends upon that person. Everyone reacts a little bit different. Again, the etiology is too much insulin, too little food, or excessive exercise. Just some personal accounts. I had a sister who had diabetes, who after pregnancy, they came in and gave her Diabetic. Remember, that lasts about 72 hours on board. We all know that what happens when your blood sugar after you have a child is your blood sugar goes down normally anyways. So she ended up and almost didn't make it because of hypoglycemia. I had a grandmother who passed away from a hypoglycemic reaction who was given orange juice in a semi-comatose state. And then I have a nephew who did not make it. So I have had 3 incidents, personal accounts just in my life because of hypoglycemic reactions. So I cannot stress the importance of watching for hypoglycemia. Decreased glucose stimulates, we know, the central nervous system to release epi. And what does epi do? Epi is one of our counter-regulatory hormones, but it also causes you to have those cold shakes, the sweats, the nervousness, the irritability, powder, confusion, and fatigue. And that was pallor, not powder. Treatment. Ingest a simple sugar, a fast-acting carb, like orange juice, soft drink, or hard candy. Once that improves, then get you a longer-lasting carb on board, such as milk or bread or graham crackers and milk. So it's okay to ingest a fast-acting carb, but you always have to follow that by a longer-acting carb. If the client is not alert, then you want to administer glucagon, 1 milligram sub-Q or IM. What's glucagon going to do? It's going to stimulate the liver to convert glycogen, which is the stored form of glucose in the muscles and cells, back to glucose. In the hospital, you're going to give an amp of D50. Now, if you've never given an amp of D50, know that it's pure sugar water. It's very thick. It's very hard to push. Even if you're pushing with all your might, you're going to push it in very slowly. One of the things you need to remember about is glucagon injections may induce vomiting. So anytime you ever give someone a glucagon injection, you always want to make sure that you put them on their side. Little mnemonic for hypoglycemia is tired, tachycardia, irritability, restlessness, excessive hunger, and diaphoresis. Chronic complications of type 1 and 2, you can see micro or macrovascular changes. When you think of micro, you think of small blood vessels. So you think of thickening of like the capillary membrane that results in decreased tissue perfusion. And again, they're saying now you can prevent a lot of this if you just control your blood sugar. This would be like your retinopathy, your neuropathy, nephropathy. Your macrovascular changes, or your large blood vessels, these are the ones that can be altered again with controlled blood sugars. This will be like your coronary artery disease, your peripheral vascular disease, and your cerebral vascular accidents or strokes. So one of the things you want to make sure that you're watching for is that you know that they're at risk for these things. We know if they control their sugar that they're at decreased risk for them, so controlling the sugar is of utmost importance. Other complications can also develop. You can see here a large list of those. But let's talk about 2 conditions of fasting hyperglycemia that can occur and what changes you need to make and what is the danger in that. The first one we're going to talk about is the Somogyi effect, which is also known as a rebound hyperglycemia. What happens is that you have a hypoglycemic reaction during the night with rebound hyperglycemia in the morning. It is most common in type 1 because too much insulin is circulating at night. Hypoglycemic episodes at night will cause the release of epi, glucagon, and growth hormone and cortisol levels that are rising in the morning. So in other words, I've taken too much insulin during the night. I'm bottoming out about 2 o'clock, 3 o'clock in the morning. But when I check the sugar in the morning, it's high because the counter-regulatory hormones have kicked in. And if you remember your circadian cycle, that's also when growth hormone and cortisol levels are the highest between 4 and 6 in the morning. So by the time you check their sugar at 6, it looks like they have a high reading because of all the counter-regulatory hormones and the circadian cycles. So the danger in this is that you think, oops, high blood sugar, let's give them what? More insulin. Let's increase their insulin. So you may even bottom them out even more during the night. Clinical manifestations is someone who wakes up and says, man, I'm having horrible nightmares, early morning headaches, waking up in drenched sweats. Management is simply checking a blood sugar at 2, 4, and 7. If they check the sugar at 2 and 4 and it's high, and they check it again at 7, at 2 and 4 and it's low, and then again at 7, 6, and 7 and it's high, then we know this is probably the Somogyi effect. So what do? Instead of increasing insulin, you actually either decrease the insulin or you change the time that you're giving it so that they don't bottom out at night. Now, the dawn phenomenon is early morning rise in blood sugar with no hypoglycemia during the night. So these people just start having high blood sugars early in the mornings. This is more common in type 1, and it's related to nocturnal elevations of that growth hormone and cortisol. Now, when will we see this then? Particularly adolescents during the growth spurts. So if you got an adolescent going through growth spurts, then they're going to go through some times during that growth spurt when they're going to have high blood sugars, especially upon rising in the morning because those counter-regulatory hormones. Pregnancy and young adulthood can also induce that. So what's the management? Again, change the time and dose of insulin. For example, if you're on intermediate, you may take it at 10 p.m. So now it peaks when the growth hormone and cortisol levels are also released between 4 and 6, and they're peaking. So let's do a little checkpoint and see where we're at. Joe Green is 18. He has type 1 diabetes. Yesterday, he was admitted to your unit with flu-like symptoms. He tells you that he hasn't taken his insulin for the last 3 days, because he can't eat solid foods. Mr. Green is at risk for developing DKA as a result of what? Polyurea, dehydration, lack of insulin, or decreased appetite. And you should have picked lack of insulin, C. Because when a patient has type 1 diabetes, he has an absolute lack of endogenous insulin. So without exogenous replacement, he's going to be at risk for developing hyperglycemia and diabetic ketoacidosis. Polyurea is simply a common symptom, and if left untreated, can cause dehydration. Decreased appetite alone in a diabetic doesn't increase the risk of diabetic ketoacidosis. So the answer was C. When assessing Mr. Green, you notice that his respirations are deep and rapid. That's called Kussmaul's respirations. This is a sign that his lungs are attempting to do what? Increase the CO2 level, decrease the CO2 level, increase the bicarb, or decrease the bicarb. Well, we know in DKA they have too much acid, right? The ketones have built up. So what are we doing? Why are we breathing deep? Trying to get rid of acid. The acid component of our acid-base component was the CO2. So we're trying to decrease the CO2 level, right? Get rid of some acids. You should have picked B. Your assessment of Mr. Green's neurological system will probably reveal alert, lethargy, tremors, or seizures. If you'll remember back in the lecture in ABGs, we said that acidosis does what to the central nervous system? It suppressed the central nervous system. So you would expect to see lethargy and disorientation. But even if you did not know this, you could have gotten the answer because alert mental status, tremors, and seizures are all stimulation of the nervous system. The only one that was an oddball different one was lethargy and disorientation. You'd expect Mr. Green's arterial blood gases to show which of the following. Well, he's in diabetic ketoacidosis, right? So you want, first of all, ketoacidosis, so he's acidic, so that's a decrease in pH. So you could have marked off B and C right off the bat. So now it's either A or D. Well, he's in ketoacidosis. So now do we have an increase then in bicarb or a decrease in bicarb? Well, the metabolic part is the bicarb, And remember, this is the base, and the higher the base, the more alkaline. The lower the base, the more acidic. So you should have picked D, decrease pH, decrease bicarb. Martha Evans is admitted to your unit with type 2. During your assessment, she tells you that she drinks a lot of fluid and she urinates frequently. Polyurea in patients with diabetes is caused by hypertension, increased osmolarity of the blood, hyperkalemia, altered fat metabolism. And you should have picked increased osmolarity of the blood. Remember, the more glucose, the more particles, the more osmos you have. Which of the following statements is correct about type 2 diabetes? Less than 50% of diabetic clients have type 2. Remember, type 2 was 90%. Its onset is abrupt, and clients often present with diabetic ketoacidosis. Remember, it's insidious, and most of them have HHNS, not diabetic ketoacidosis. It's the predominant type of diabetes in young adults. Remember, that's type 1. So that only leaves what? D. It develops most commonly in midlife or later. Glucotrol is commonly used to treat type 2 diabetes because it stimulates the secretion of cortisol, increases serum glucagon levels, increases insulin production and the number of insulin receptors on the cells, or delays absorption of glucose. And the answer to that was C. This is an oral hypoglycemic agent that produces more insulin by increasing the number of insulin receptors on the cells and decreasing hepatic glucose production. It does not increase cortisol or glucagon levels or delay absorption of glucose. So that's your checkpoint to kind of see where you're at this point if you're understanding this content. Let's look at some other topics related to diabetes mellitus. Foot care. Foot care and foot injury is a common complication of diabetes and hospitalization and leads to amputation. Half of diabetics develop what we call hammer toe and claw toe deformities. If you need to look that up and you're not sure what those look like, then you need to Google that and YouTube it, and you'll see some pictures of that. I will tell you, once you look at it, you'll wonder how they can even put shoes on. Decreased blood flow is going to cause slow healing, and neuropathy is going to cause that tingling, burning, and itching. They're going to become very insensitive to touch and temperature. Things to remember before teaching: you always want to look at the scope of practice and make sure that you are teaching within your scope of practice. And then you want to look at the health literacy in the United States before teaching. 40 million Americans cannot read or write, and half of those live in poverty. With that said, you can't expect that everyone you hand a pamphlet to can read and write. The U.S. average reading level is the 8th grade. Most pamphlets are written at the 10th grade level. We have an issue. Watch labeling clients as non-compliant. Sometimes it's strictly that they cannot do it. We had a mother who was being labeled as non-compliant because she kept coming in with DKA. Well, the reason she was coming in with DKA is because of some other social issues that she had, that if someone would have just took the time to question her, they would have figured that out. And always, always, always assess the level of knowledge. Patient teaching related to foot care. This on page 1453. You always want to check the feet daily and tell a diabetic to check the feet daily. If you're going to a physician and you're a diabetic and they're not making you do eye appointments, they're not checking your feet, they're not checking your skin, they're not doing these common things that should be done, then you probably need to make sure that you're talking to your healthcare provider to say, you know, we really need to be looking at these things. Wash your feet with mild soap and lukewarm water. Not watch the harsh chemicals, harsh soaps, perfumes. Don't use those. Take care of your toenails. We'll talk about that in a little bit, especially after bathing, because they'll be softer. And of course, always cut them straight across. You don't want to cut close to the cuticles, and you don't want to cut anything except straight across. Take care of corns and calluses. That doesn't mean cut them off. That even using over the counters, you have to be very careful, because some of those contain acid and can cause skin ulcerations and infections. So you really need to see your physician for corns and calluses. Protect the feet. Keep your blood flowing well. Wear good fitting shoes. No lotion between the toes. If you're going to put lotion on, don't put it between your toes. No nylon socks. You want to use cotton socks. Patient teaching related to diet and exercise. With type 1, you may need to increase calories. Diet and insulin both may be necessary to control it. You may need an equal amount of carbs throughout the day, with snacks as well as bedtime snacks recommended. Now, with type 1, if they are going to do a lot of physical activity, they also will need additional carbs. Very important. With type 2, now we want to decrease caloric intake. Low fat, no snacks are recommended unless they're on insulin, and here's the daily allowance. You do need to remember this. Protein, 10 to 20%. The remaining 89 to 90% should be distributed between your fats and carbs, with 50 to 60% going to carbs, 30% fats. Of those fats, saturated fat should comprise less than 10%, and cholesterol should be less than 300 milligrams a day. Fiber is a big thing these days, and increasing your fiber intake. You want to have about 25 grams per day. Good sources of fibers like beans, cereal, fruits and vegetables, whole grains. Why less fats? Because they're already at an increased risk of cardiovascular disease, because if they keep up with their fat, keep increasing their fats, then they're going to have an increased risk of MI and stroke. So you want to make sure that they're decreasing that. Simple versus complex carbs. Of course, complex are better than the simple carbs. Even though research supports that if you let a diabetic have up to 5% of their diet with simple sugars, they are more compliant. In other words, let them have a 1 or 2, 3 midget Tootsie Rolls versus no Tootsie Rolls, because when they go on binges, they tend to eat more if they are not allowed to have certain things that they do like. Helpful hints for diabetics: use non-stick sprays. Limit, of course, your things that are heavy in fats, your salad dressings, your butters and gravies, your fried things, the good stuff. Choose 1% in skim milk products. Eat red meats no more than 3 times a week. Choose seasonings moderately, and watch your sugar and salt. What about alcohol and diabetes? To indulge or not to indulge? You have to be very careful about alcohol, because a lot of times we assume that alcohol is a hyperglycemic agent that increases alcohol. But actually, someone who is on an oral hypoglycemic agent and mixes alcohol has to watch for hypoglycemia. Moderation is the key, and it tells you there if they're going to drink, they suggest 1 to 2 drinks per day. That would be 1 for women and 2 for men. A drink is considered 5 ounces of wine, 1.5 ounce of hard liquor, or 12-ounce beer. Now, the risk of blood sugars, again, you have to be very careful when we're talking about that, because alcohol affects your body's ability to get over a low blood sugar. And that's the danger, because you have to be very careful, because if the body's having to fight between alcohol being a danger to the body, a chemical danger, a toxin, because the body's recognizing the alcohol like a poison. So what does the liver want to do? It wants to get rid of that poison. So the liver wants to clear it from the body quickly. In fact, the liver won't put out any glucose again until it's taken care of that alcohol. So that's the danger. If your blood sugar starts dropping, that liver's not going to back up and convert that glycogen over to glucose, because it's too worried about the alcohol that's in the system. Very dangerous situation. Diabetic food groups and products can be very expensive. We all know that. They need to learn to read the labels, because sometimes you think you're getting a good deal till it says per serving size, and there's 3 serving size in a little thing. So very important about reading labels. In our Sim Lab, we're going to be going over diabetic labeling and diabetic reading and setting up some meal plans, so we'll be doing a lot of hands-on with this later on. The use of sweeteners is acceptable: sugarless, sugar-free. Make sure they're checking calorie count, because if something says fat-free, it's full of sugar. They're going to make up for it. If something says sugarless, it's full of fat. You can't win. Exercise is very important as well. With type 1, of course, we are wanting to lower maybe the amount of insulin that they have. With type 2, it's basically weight loss and increasing the binders to the receptors. The goal is to exercise 60 to 80% of your maximal heart rate for the client's age. How do you know what this is? You subtract their age from 220 and multiply by 60 and 80%. So if you had a client who was 20 years of age, what would be their maximal heart rate? You'll need to know this for test purposes. 220 minus 20 is 200. 200 times 60% is 120. 200 times 80% is 160. So you would want their maximal heart rate during exercise to run between 120 and 160. Remember the little acronym FIT during exercise, FIT. F stands for frequency, about 3 times per week. I stands for intensity, 60 to 80% of that maximum heart rate. You know how to figure that now. I just gave you the formula. And T, you want it anaerobic, and you want it for about 20 to 30 minutes with a 5 to 10 minute warm-up. So remember FIT. There's a little bit on the pediatric considerations on page 992 through 1006. We know the incidence in type 1 and 2 is increasing in children. 1 out of 3 will develop diabetes. The most common endocrine disorder in children now, and a lot of that is because of the obesity. There is a new MODY type that's occurring later on in adolescence and young adulthood. Just know that there is a new type. One of the things you're going to have to be very careful with these children is that everyone's on board when they're in school. That the school nurse knows how to treat it. Teachers are learning how to treat it. Coaches, if they're playing sports, need to know how to treat it, particularly if they're doing a lot of after-school practices. They need to make sure that they are hydrated. They need to make sure that they're eating a snack because they will burn those carbs, and they will decrease and wipe out that sugar pretty quickly. The hemoglobin A1Cs differ just a little bit for children. You can see there from 0 to 6, they are considered maintained if they're between 7.5 and 8.5. 6 to 12, you want it less than 8. 12 to 19, less than 7.5. And then greater than 19, they become an adult level where you want it less than 7. What is their role? Depending upon their age, we do want them in there helping. Remember, kids can only tolerate so much teaching at a time. About 15 minutes is about all they can handle. An adult, about 45 minutes is all they can handle. So with adolescents, you want to make sure that they're washing their hands and that they can do that. Okay, it's time to do your sugar. What do you need to go to help Mama do? Wash your hands. So they would go wash their hands. For a preschooler, now you can even start teaching them, depending on the maturity, how to collect the blood, and they can help with that. By school age, they really should be giving their own injections with supervision, as well as collecting the blood and washing their fingers. So you just keep adding on depending upon maturity of that child. Now, which age group has the most difficulty adjusting, do you think? If you think adolescents, you're correct, because it is a time of stress. They're trying to be perfect. They're trying to fit in. They're wanting to fit in with their peers. And no matter what anyone says, having diabetes is being different. So some will be more upset about a candy bar than an injection. Now, adolescent girls with diabetes tend to have frequent fluctuation in blood sugars, especially increased blood sugars before, during, and after menses. If they're in a family situation that's stressful, divorce, when they get ready to leave home, all that stress, that cortisol we know is increasing, that increases their glucose levels as well. In children, one of the telltale signs now is called acanthosis nigricans, and this is a condition marked by a thickening and hyperpigmentation of the skin. It's a common sign of insulin resistance long before it progresses to diabetes. So it's a little warning sign that we've been blessed with. You want to make this part of your routine assessment with obese children by simply looking at the nape of their neck and their armpits. You may be also on the abdomen, the groin, and the elbows. But the place you mainly want to look is the nape of the neck and the armpits. And what it will be is a very discolored area. Go to this website later. I would pull it up, but it won't let me. So with acanthosis nigricans, particularly along the back of the neck, you'll see this. And you'll see a little line, a darkened line. If it's just a small line, it's a grade 1. If it's 1 to 2 centimeters, it's a grade 2. 2 to 3 centimeters a grade 3, and greater than 3 centimeters, it's considered grade 4. So only up, for example, grade 3, it's 2 up to 3 centimeters. Once it gets to 3 centimeters, it becomes a grade 4. And you can see here it's a very darkened area. My sister has type 2 diabetes, and she developed this when she was younger, but we did not realize it. But one of the things she did have was acanthosis nigricans. I remember my mother going in there and scrubbing and scrubbing and scrubbing her neck, swearing she never washed it, when actually this is what she had. Now, she would scrub it so much it got so red, I think she thought she got some of it off there, but it would come back again. So this is a warning sign. If you have someone on this, you can actually see that line decreasing if they start losing weight, they start eating right, and controlling their sugar better. Things to keep in mind: DKA in children is considered a medical emergency. Remember, we talked about earlier, recurrent UTIs and vaginal infections, particularly candidus, are often early signs of type 1 in adolescence. In a child, 8-hour fasting is greater than 126, a random greater than 200 any time of day, and oral glucose greater than 200 on 2 occasions. So in other words, basically the same criteria as an adult as a child for diagnosing diabetes. Does insulin requirements change as a child grows? Why or why not? And the answer was yes, and we talked about that because of the growth spurts, because of the circadian cycle of growth hormone, of cortisol, of some of those things that we talked about. Stress, starting menses if it's a female, all those things are going to impact their insulin requirements. Most children are controlled with BID injections that are given at breakfast and in the evening meal. In children, maintaining that blood sugar level between 80 and 120 is ideal. Now, that does not mean that they can't eat birthday cake. That don't mean they can never have a hot dog or piece of pizza. They just have to make sure that they're watching their exchanges and they're counting their carbs and bolusing for those as needed. Now, the book suggests in order to gain the confidence of a child, the nurse demonstrates the technique by giving a skillful injection to the parent who then gives one to the nurse. What's your thoughts? Most people would say this is going a little overboard. What they're trying to do, and a lot of your teaching hospitals will actually have a lot of models that they actually show this on, as well as some people just use a simple orange. With children, use the pinch technique and inject at a 90-degree angle, and rotation of the sites would be the same as the adult. So here's an example question I may give you based upon growth and development. Considering a child's developmental level in diabetes care is essential, the RN should include which information in teaching the parents of a recently diagnosed toddler? Select all that apply. Allow the toddler to assist with injections. That wasn't till school age. Bonk. Prepare meat, vegetables, and potatoes with each dinner. We didn't say that. Test the toddler's blood glucose every time he goes outside to play. Well, what if he goes out to play 10 times in a day? No. Allow the toddler to assist with cleaning off his fingers before the monitoring. Yes. Allow the toddler to choose food selections from options offered. Yes. Remember, they want selections, and you are offering the correct options because that would increase autonomy in the toddler. So your answer should be D and E. One of the things that's out there is called sick day rules. And when you're sick, you should be checking frequent blood sugar levels about every 1 to 4 hours. Assessments for ketonuria every 3 to 4 hours while they're sick. You want them to take insulin or oral hypoglycemic agent. Monitor their INO, their temperature, their mental status. Monitor their intake. And if they can't hold down fluids or medications, you want to notify the practitioner or the healthcare provider. The reason sick day rules are important because most people think I'm sick, I shouldn't take my insulin. But you remember all those counter-regulatory hormones in your body. If you don't take it, then they're all going to kick over, and you're going to end up having hyperglycemia. Now, if someone's vomiting diarrhea and can't keep nothing down for hours and they're sick, they really need to seek help. Some current research, they are looking at inhaled insulins. They are looking at intranasal insulins to supplement particularly your basals, your meal times. Non-invasive, we've already talked about some of those things. They're looking at glucose watches, glucose measurements through your saliva, tears, finger probes. They're trying everything to make these better for diabetics. Insulin patches, transdermal deliveries, making it through an insulin patch. Some of the things, the newer, machines also have alternate testing sites where you can test on the upper arms by using just a different depth of the needle. That has helped some with compliance as well. Now, they have proven that the levels there are not as good as getting them in the capillary. So if you're getting some high readings by doing the alternate sites, you would still want to go ahead and do it at the end of the finger just to be sure. End of life issues. What's your thoughts about keeping strict diabetic control at the end of life? One of the things, when my grandmother was getting ready to pass, she was wanting certain things. And at that point, it was like, let's let her have what she wants. You get to a point, that there is some time when you have to say, caring, humanity, integrity, you know, what's important to that patient. And if we know it's the end of the life, it's the end of their life, they're getting close, and they're at a point where they can have that candy bar if they want that candy bar, then we probably really should let them have that candy bar. Last thing to remember, I want you to wish more. I want you to remember wish more when you sum up diabetes. W is for weight control. I is for insulin management. Learn about it. S, remember the sick day rules. H, hypo and hyperglycemia signs and symptoms and management. M, maintenance of food care. O, no smoking, not good for a diabetic. R, you're revving up the engine to exercise. And I, do your eye care and get evaluated. Remember, laughter is the best medicine. Don't forget. Thank you. I've enjoyed our adventure. If you need any kind of assistance or help or don't understand something, feel free to contact me and I'll be glad to help you.